My name's Jane Anderson. I'm a physician in London and I work at Public Health England, and it falls to me to introduce the speakers for the next part of the afternoon. It's a really interesting session, making the investments. We've heard a lot about what we think we should be doing, what we'd like to do, the targets we're aiming at. So now what? Where are we going to put the investment? How's it going to work? Now we've got some big talks. We haven't put a panel discussion at the end, but if the speakers don't necessarily use up all the time, we might see how we could work that. But basically the first thing to do, great pleasure, to introduce Badra Sam, who is going to speak to us on the 1990 target, a smart and doable investment. There you are. Excellent. The mic is all yours.
This is next and back. Okay, good. Good afternoon. First of all, I just would like to thank everybody, and thank in particular the organizers of this summit to give us the opportunity to talk about 1990. I'll just start by saying that there is one word that or two words that we use at the moment very, very frequently, and that is ending AIDS. And when we talk about ending AIDS, we have two types of reaction. We have those who see it as a hope, and that certainly we can get there, and that create enthusiasm. And we have the skeptics. And the skeptics actually take us quite often to our own publication in UNAIDS, which you must have seen. They take us to the fact that we released data saying that as of December 2013, there were still 25 million people living with HIV/AIDS. At the same period, at the very same date, there is still 2.1 million new infections, and there is 1.5 million deaths among adults and infants. So if you have this, how can you think and talk about end of AIDS? But there is also the flip side of the coin that I think it is important to have a look at. The flip side of the coin is that over the past 5 to 10 years, we have seen a 38% decrease in infection, and we have seen a 35% decrease on AIDS deaths. So there is some trend there that probably we can build on and start working towards ending AIDS. And if we start looking even what is behind these two numbers, what we will see immediately is that those countries where we have new infections coming down are those countries where we have, in green here, the highest antiretroviral treatment coverage. And those where we are not seeing very, very steep decline are those where antiretroviral treatment coverage are not that high, and those are in blue. So that's the environment we are working on. When we drill even down into our data, and that go into some modeling that we have done, the slide that you see here is what we find. And that slides show that if we continue to do business as usual, we'll certainly keep having a reduction in number of deaths, reduction in number of infection, but actually we'll be maintaining the epidemic. And there is a second road. A road is to be massive in combination prevention. And we model that if we do massive combination prevention scale-up, including massive treatment scale-up, we'll be able, according to our projections, by 2030 to make almost AIDS no longer an epidemic, to make people no longer dying of HIV/AIDS, and to make new infection a very, very rare event in the world, then contemplating the end of AIDS. But before going to what we think should be that package of intervention, especially in the area of treatment, let me tell you where we come from. We come from just 2.5 years ago from a big launch that we did in Abuja in front of heads of states and government from Africa, where we launched an initiative that is still there, that is called Treatment 2015. And that initiative was aiming at reaching 15 million people on treatment by 2015. And of course, as we do in UNAIDS, every time we launch an initiative, we have what we call a launch document. In the launch document, we came with 3 statements. We say that we are launching this initiative, which is 15 by 15, which is very, very heavily reliant on treatment. And we know that treatment prevents death, treatment prevents new infection, and treatment saves money. You are all experts of treatment. So I think I really do not need to make the case to tell you that this is a true statement based on evidence. So my next 2 or 3 slides will be very, very quick because these are slides that you know. First, treatment prevents death. I think if you just look at what treatment has done in the developed countries, this is what treatment has done. We have seen an increase in life expectancy of people living with HIV/AIDS, and this is the life expectancy that we calculate, that we projected, of a person who is 20 years old living with HIV/AIDS in antiretroviral treatment in the developed countries. And we have been following the life expectancy of that person over the few years since the introduction of antiretroviral treatment. And as we speak, the life expectancy of that person equals the life expectancy of a person not living with HIV/AIDS. And you will tell me, but this is developed countries. You're coming from a developing country, so what's happening there? What's happening is this. This is what has been the life expectancy of people in those countries where HIV is very, very high prevalent. We decided to put here Botswana, South Africa, Kenya, Swaziland, Uganda, Zimbabwe, which is actually a slide that I borrowed from Ambassador Burke. And this slide shows that when the HIV epidemic has hit the continent, we have been seeing a dramatic reduction of life expectancy. And since the 2000s, early 2000, when we start scaling up treatment, you see how life expectancy is going very, very much up. So in our launch document, we say, 1, treatment prevents death. The second thing we said in that document was that treatment prevents new infection. I think today, everybody knows the HPTN 024. Everybody is aware of the partner studies that have been published recently at the Boston conference, which also which have been seeing that treatment is really prevention among discordant couple. And you will again tell me, well, this is among discordant couple. It was very, very much studies that have been looking at men who have sex with men. What about the heterosexual population in Africa? Then I have an answer for you as well. And the answer is a study that has been published by Tanza in Science not that long time ago, and that have been saying that basically demonstrate that for every 1% increase in treatment coverage, there is a 1% decrease in new infection. And Julio Montana recently published the same data in the province of Vancouver, in the province of British Columbia as well. So we say treatment 1, save lives, treatment prevent new infection, and the third one that we said was the treatment saves money. And this is some modeling that have been done by my friend and colleague Ruben Grange here, that have been looking at what are the potential saving of different treatment policies in South Africa. And here we have, of course, in the blue line, 200 CD4 as the cutoff to put people on treatment. In the light gray line, test and treat. In the darker gray line, 500. So if we just implement the current WHO guideline in South Africa and compare that to a policy of 200 CD4, the saving that we expect is $17.3 billion by 2025, 2030. And test and treat is $28.7 billion. So yes, I think we can be confident and say that if we scale up treatment, we'll be saving life, we'll be preventing infection, and we'll be very, very much saving money. So where are we in terms of treatment scale-up? This blue line that you see here is the level at which we have been scaling up treatment since 2003. And the blue dot that you see in this slide is basically the target that we have agreed for at the UN General Assembly to reach 15 million people with treatment by 2015. And you can see that actually we look like we're in a quite good shape, because the trend is pointing to the blue dot. And we are convinced, and we know, according to the level of scale-up that have been happening, that by 2015 we will reach and we will even have more than 15 million people on treatment by 2015. So we are confident that by 2015 we'll be claiming success. So yes, we can claim success, but it is full success. We don't believe that it is full success. We'll be celebrating because we set target and we'll be reaching the target. But is that enough? No, because there are something that has happened since then. Because when we put 15 million people as a target, it was based on WHO guidelines at that time, 2011, where WHO would come with its guideline and say that people should be put on treatment when they have the threshold of 350 CD4 count. Since then, WHO came with new guidelines. Since then, we have new evidence saying that treatment is prevention. And that's why the board of UNAIDS met and say that we have new information, we have new recommendation, we would like you to work with your partners and set new target. Recognizing, as I said, all that, but also recognizing that target drive progress. So we have been consulting over the past few months with all our partners to see what should be the next targets. So we have 4 options on the table. The first one to say that, to sleep on our laurels and say, actually, we have 15 million, that's good enough, why take another risk? I think nobody in this room will say that this can be an acceptable solution. The second option is to say, let's continue with the current pace. Today we know that every 16 seconds, somewhere in the world, someone is put on treatment. So why don't we continue that pace? That's good. But there are certainly other options. The third option is, let's make sure that we have a full implementation of WHO's 2013 guidelines, 500 CD4. And there are other people who have been in the room in all the meetings that we have organized saying, if you look at the history of the guidelines, it's a moving target. Based, as we move, science is coming. And today, you go to the United States, you go to British Columbia, you go to France, they are moving to test and treat. Why don't we factor that in any target that we want to put? Because the window of opportunity is coming thinner and thinner. So we might not have another opportunity to set another target. Why don't we think of a final target once for all? So the compromise we come up with is what we call 90-90-90. What 90-90-90 stands for, Michelle said yesterday, is to make sure that 90% of people living with HIV/AIDS know their status. Out of those, 90% are on treatment. Out of those, 90% are virally suppressed. So what is the difference between this philosophy of targeting from the old philosophy, old quote-unquote philosophy of targeting? There are 4 differences. One is, in this 90-90-90, we're moving from looking at a single number, which was actually measuring people who initiate treatment, to a cascade target that look at quality of treatment, look at adherence of people on treatment, which is very, very much important to bring viral load down and then reduce transmission and keep people alive. The second shift is that we are moving from focusing on death to focus on death and new infection. The third one is that we are no longer looking at just the numbers. When we go and look at out of the 14 million people who are currently on treatment and go and be more granular, we'll realize that there are some countries that are well off, others that are not well off. There are some populations that are well off, others that are not well off. So we'll be looking at more at equity in this new target. And of course, the last one is, we know now that if we invest very, very heavily today, we'll be able to make big savings. So this target is calling actually for a big front load investment on treatment so that we can put people immediately, as many as possible people on treatment in order to control the epidemic. So what is our starting point? Our starting point is 37% coverage. This, you might say, oh, we are going down. Actually, the 37% coverage is a new way of UNAIDS and its partners to calculate coverage. We used to calculate coverage as the number of people on treatment divided by the number of people eligible to treatment. And then from one year to another, or from one guideline to another, we would have difficulties comparing coverage. Now, we have decided to use a new denominator, which is the total number of people living with HIV/AIDS. So 37% is the number of people living with HIV/AIDS who are on treatment divided by the total number of people estimated to be living with HIV/AIDS. And of course, this number is bold, but if you go and start looking at being more granular, you will realize that, of course, the coverage is very, very variable depending on where you are in sub-Saharan Africa, in North Africa, in Eastern Europe, Latin America, or in Western Europe. One fundamental question that people are putting on our table every single day as we are starting to push for 90-90-90 is it realistic? Is it possible? And the answer that we tell them is that the way UNAIDS has been always working is that we believe in equity. If something is possible in a rural area of Senegal, that should be possible in a rural area or in a city in Cambodia. If something is possible in the United States, why it cannot be possible in Ukraine or in Swaziland? So we just need to make sure that we put the ingredient together, the recipe together, that is working somewhere, to make sure that we put it everywhere else. So let's look at the first 90 and see whether in the world somewhere there are some countries that have reached the first 90, which is 90% of people with HIV/AIDS knowing their status. This is some data that we have collected from Rwanda, Malawi, etc. And this is based on DHSS analysis that we have done, and that have been looking at the percentage of population that have been tested at least once. And look at Rwanda here, and look at Malawi. We realize here that in 2014, I'm not talking about 2020, we have as high as 90% or as high as 80% of women living with HIV, women living in Malawi have been at least been tested. So if these good results have been achieved in Malawi, maybe we can achieve them in Bucharest. The second 90 is, can we achieve 90% coverage? We do think it's possible. We have Brazil that have been telling us that out of the number of people eligible, they have 72% coverage. Botswana telling us that out of their number of people eligible, we have 71% coverage. But of course, as I was saying, the denominator has changed. So we have a different way of looking coverage. But look at the next slide that is coming. What we have been looking at recently in our way of fine-tuning and reanalyzing the data that we have in our disposal came to this one. In sub-Saharan Africa, if we look at those people who know their HIV status, about 90% of those went on access to ART. So actually, when people know that their HIV status, they go and reach out and have access to treatment. This is what we're having. So testing is definitely key. The next one is 90% people living with HIV/AIDS on treatment, virally suppressed. Is that possible? My next slide is showing you a survey that has been done in a representative sampling that have been done in Rwanda. And this is what we have. Nationwide, it is estimated 83% of people living with HIV/AIDS in Rwanda who are on treatment are virologically suppressed. And whatever you take as a site, you have very, very high viral suppression rate, from 80% to 100%. That's quite good news. And again, if it's possible in Rwanda, maybe it can be possible somewhere else. But how those countries get there? That is a trick. You can show one good example, two good examples. But it's important to go and see why they have been successful. That's why preparedness will be very, very key. In preparing our communities, our countries, the world to get to 1990, we know that there are at least 5 key challenges that we have that needs to be overcome. The first one is societal. The first 90 is about knowing the HIV, knowing your status. And today, we know that 1 out of 2 people living with HIV just does not know its own status. So we have lots of things to do. We need to analyze why this is happening. This is happening because there are still punitive laws and policies. There is still stigma and discrimination 30 years after the beginning of the epidemic. We need to do something on that. This is just a slide showing the countries that report in their national AIDS program that they take into consideration transgender. It's so, so slim. The second one is about delivery challenge. This one I will just pass by because I'm sure that you have seen this paper in the Lancet, which is basically saying that for every 1 kilometer, a person living with HIV/AIDS is away from a health facility. His chance to be among those having access to antiretroviral treatment is reduced by 2%. So maybe we need to start thinking of alternative delivery model, where the entire system is not just based on the health facilities, but a strong community-based response. The third one is about some cost. This slide basically shows what are the facility level cost of providing treatment to one person. There are many things that are here. The cost of human resources, the cost of drugs, everything. But still, if you just look at it and realize also that when PEPFAR or Global Fund is giving money to a country, the money just comes from there. And they would like to have probably a unit cost to make their calculation. But this cost is very, very variable. It moved from 136 in Malawi to 682 in South Africa. So starting to look at how we can harmonize that would certainly merit some attention. When it comes to cost, I just wanted to add one thing, which will be a cost challenge that we'll be facing in the coming months if we are serious and we want to implement 90-90-90. And it's the cost of laboratory diagnostic. I think the AIDS world have been very, very good in looking at the cost of drugs. We have been able to reduce dramatically the cost of antiretroviral treatment using different techniques. Today it's less than $80. In Malawi, it was $15,000 just a few years ago. So we did a lot of work, but we have been putting as an orphan the cost of diagnostic. We have not been looking at diagnostic. But if you look at 90-90-90, the first 90 is very, very lab dependent. It's testing. The last 90 is also very, very lab dependent, viral load suppression. So it's very, very important that we start looking at that market, because it is a market that will be growing, where we need to do something. Otherwise, the cost will be on us. We have been trying to put just here some scenarios. Look what the place of viral load will be as we scale up. Today, if we just stick on the current WHO guidelines, you will see how CD4 will be little by little plateauing and how we'll start having viral load going up, because in the WHO guidelines, they are pushing for viral load for monitoring. If you go for test and treat, this is what we'll be getting. We'll be getting CD4 coming more and more down in the market and viral load going up. Do we have today in our facilities the capacity to meet this growing demand? That is there. That is tomorrow or the day after tomorrow. The response is no. In blue is our current capacity to do viral load tests in the countries. In gray is what we expect will be the need in terms of viral load tests to be done in the world in the coming few years if we implement 90-90, if we implement test and treat. I think preparedness is very, very important. It is very important that we start looking at this, building the capacities, and looking at the resource implication of viral load. We have been also looking at how much weight countries are putting on lab diagnostics in their proposal to the Global Fund, in their COPs, in their national programs. It's quite interesting because it's very, very variable. A country like Malawi is putting 4% of its AIDS response on lab and diagnostics. South Africa, 15%. Rwanda, 6%. And it's the same needs. And as I said, lab will be very, very important. So I think this is something that we need to start collectively looking at and see what we can do about it. To start thinking forward, UNAIDS, together with WHO, the Clinton Foundation, PEPFAR, the Global Fund, CDC, ASLM, UNITAID, UNICEF, just launched what we call a Diagnostic Access Initiative in Melbourne a few months ago to try to start addressing today the weight of lab in our response in the coming months. The third challenge is the cascade. I will not spend 1 second on it because this is something that you all know. Not that you don't know the others. And the third one is financing. I think the more and more people are talking about domestic financing. Let's ask the countries to put resources in their AIDS response. I think it's good, but we need to be careful. We need to be careful because the financial weight of the AIDS response is something that is very, very variable, depending on the country that you're talking about. In Malawi, if you ask today Malawi just to take care of the cost of its drug, it will eat up to 8% of the GDP, as compared to Senegal, which will be 0.1%. So when we talk about shared responsibility, global solidarity, domestic funding, I think that we need to weigh in the capacity of the countries to put money and the toll that the HIV is taking into their work. So we are talking about 1990. What will be needed just for drugs and diagnostics? We think that if we implement 1990, by 2020 we will be plateauing in terms of resource need, and it will be around $14 billion. And then we start having the resource need going down. And this is quite conservative figures. And I think if we are very performant, we'll be starting to see even a further decrease in the resource that will be needed to put people on treatment and make HIV infection, new infection, a rare event. And if you look at the resource need to purchase drugs using the conservative and a more aggressive, this is what we will be having. This is my last slide, which I would like all of us to just take a big picture and keep having it as we discuss with government, as we discuss with our friends and our partners. This slide shows on the left-hand side new infections in different scenarios. On the right-hand side, deaths in different scenarios. The scenarios that is up is the conservative scenarios, that we are very, very happy with what they are getting here and say, let's push for that. The next one is just to implement 1990 by 2020. Today, if we are able collectively to put 90% of people with HIV/AIDS on treatment, out of those 90% virology suppressed, by 2020, we will be definitely making new infection a very, very rare event, and will make AIDS-related deaths something that is very, very minimal. I thank you very much for your attention.
I think we've probably got time for one question. Thank you very, very much for a really interesting and thorough overview of going forward and where we may be going. Any one burning question from anybody? No, I think you've stunned us. Oh, actually, Andrew, can somebody bring a mic to Andrew at the front here? Yeah, someone's coming.
Thanks. Thank you very much. That was really, really nice. This is a point that I made yesterday in the comments at the end, but the thing that slightly concerns me is, with these targets, which I think are great, is to how we maintain the other target that we need to have, which is that levels of condoms sex don't increase. And I saw in the GAP report that it says even at the moment in sub-Saharan Africa, only 8 male condoms are available per year for sexually active individuals. So just a comment really to express a kind of concern that behind all this, with the focus on antiretrovirals, that we don't lose the focus on condoms and actually understand and appreciate how much they're helping to control the epidemic at the moment as well.
Thank you very much. I think your question is a brilliant and very, very valid question. You know, it's very, very clear to us that alongside treatment, it is very, very important that we put together bold, traditional prevention target and stick to that. It just happened that sometimes you're invited to talk about treatment. It's difficult to talk about everything else. And another thing I must say is that the treatment community has been quite more aggressive, actually, in meeting this one example and setting targets. The PCB asked us to set targets on treatment and other preventions. The treatment community worked very, very quickly, and now they have their target. The prevention community, even though I think it's very, very timely that we start forgetting the notion of treatment and prevention, but the traditional prevention community is still working on target. And we hope that by mid-year next year, we'll be having prevention target that should go alongside this new bold treatment target. But should we wait to have the prevention target to start pushing for the new treatment target? We discuss about it, and we think no. Because every day that we lose thousands of people. So we just need to start. But also by putting a treatment target there, it will also push very, very heavily for prevention target. But again, I very, very much agree with you that we should not take just treatment in isolation. We need to put it in the context of a broader response, including condom promotion.
Thank you very much indeed for that. We'll look forward to that next set of targets in the next few months as well to match against this. But thank you for giving us a very stimulating presentation. Thank you very much.